So today we have a very interesting session. So you should get used to it, all of you, not only urologists. So Alexander will start. Alexander, the floor is yours. Thank you. Good afternoon. This is the third day of our 18th Assembly Moscow Health. And first 2 days gathered over 30,000 participants. So over 1,500 news pieces of news were released about this event. Over 100 workshops, different discussion venues within this assembly. And of course, the assembly is not only experience exchange, not only breakthrough technologies, but also, which is also important, it's also the results of the contest Festival of Life. It's a contest of professionals, of experience exchange, and the possibility to get to everyone the best practices, the innovative technologies to the large public. And before starting this round table, the roboticized surgery, we would like to present the awards to the winners and Specialist of the Year in the nomination Urologist. So to give this award, I'd like to invite here the Chief Urologist of Moscow, MD Dmitry Pushkar. Dmitry, please. Thank you very much. I'd like to separate our specialty, and if you have been at this award presentation, so it's very important to award young doctors. It's important for all of us, because I think it was under this unique feeling that we have future potential, which is very good. And every year we are trying to independently assess urologists. And I'm very happy to invite here to the stage Dr. Ruslan Trushkin and to give him a diploma for his victory in this nomination, Best Urologist of this annual festival Formula of Life from the Moscow Health Department. So here's your diploma. Let's take a picture. I'm very, very glad to give you this award, and I know Dr. Trushkin for a very long time. There are different urologist departments, and there are urology departments that have some tradition, that are not, let's say, easy departments, and departments that solve some complicated tasks. So Dr. Trushkin is the head of the urology department, where there is also emergency care, where there is common urology, and where there is nephrology. And I'm very glad that it is you who won this award. A couple of words, and then we'll start our scientific part. Thank you very much, Dmitry, for this high assessment. You already said that our department also has this nephrology service. It's our specifics. We make some surgeries on transplanted kidneys. We work with patients with dialysis, and I'd like to thank you, because during these last years we really feel your support, your moral support, your material support. So we're really getting high-tech equipment. We feel methodological support, and of course, as a department that works with very, very rare nephrologic diseases, we will do everything that's possible that this urological spectrum was extended thanks to this nephrology. Thank you very much, very sincerely. Thank you. Thank you, Dmitry, for this award. And I'd like to also welcome our international guest, very honorable guest, As I mentioned many times, our assembly is the biggest international event, one of the biggest events, and I'd like to welcome Alexander Motry, professor of Ghent University, founder of the Robotic Surgery University of Ossi Academy, MD, professor. Let's welcome Alexander. And we start our roundtable. So, robotic surgery. Dmitry, the floor is yours. Thank you very much, Alexander. I will use this mic because it's more convenient. So, you know, we're really trying to have a lot, to be able to talk a lot about robotics medicine. It's not only robot-assisted surgery, though there was a section about robotics, robot-assisted surgery. There was a session about screening, about future of medicine, about if we need surgery and what kind of surgery, if any. And I'm very happy that Professor Motry participated in all of these sessions as the head of the biggest in the world educational training center of robot-assisted surgery. We all know very well that Professor Motry performed a lot of surgeries in our country, in Russia, and many specialists were trained in his center, OC. But the main thing is not that. You should know about it. Why? Because here in the room there are people who are directly interested in robot-assisted surgery. And so today in the healthcare department, our urologists make a course in Russia in Russian, and that's very important. And so all people who are present here today, present urologists, I mean, who work with laparoscopic urology, robot-assisted urology, who just starting learning it, all these specialists will be invited, that's for sure, will be invited to the center ORC under Mr. Motry direction to be trained to learn robot-assisted surgery, and that's a great matter, and thank you very much for this. And the last thing before we start our scientific session, and I'll give the floor to Professor Kalantarev, I'd like to tell you that we have a responsible person in Moscow who's responsible for this program, and this person participates here with us today in the session. It's Professor Konstantin Kalantarev, who is responsible to prepare Moscow specialists based on RC, so on RC base. So it's on the support of Botkin Hospital, where we have Moscow Simulation Center. It's very important. Why? Because it's what we call this ongoing medical education. So this direct ongoing medical education, medical training. So in robot-assisted surgery, that's how it's organized. And the last but very important thing, I'm very happy to welcome here the team of operation nurses, surgery nurses. I see our nurses here, and I'm sure there are other nurses as well. So who are different stages of their practical activity, really learned, found the opportunity to learn their part of how to help to assist in this robot-assisted surgeons. And as chief surgeon, chief urologist, I'd like to ask Professor Motry to provide this course for surgical nurses in Russian. So based on your So you'll tell us about it later. And I give the floor to Professor Kalantaryov. And I'm very happy to see you all here. Thank you very much. So good afternoon, dear colleagues. So today started very interestingly. In the morning we had a session for the first time, I think, when medical nurses spoke and told about their experience from different Moscow facilities, about their robot-assisted experience, and about their look from the point of view of surgery nurses. It's very important, it's very interesting that this initiative was supported. And now we understand that when we talk about robotic surgery, we don't talk only just put some words in the air when it just started a couple of years ago, when Dmitry started this robotics program. A couple of years later, this term robotics program was for the first time introduced into the Russian medical environment, and it became evident that it's not just a doctor, it's not just a specialist, it's not only patient, it's not just a very complicated, hard machine, robot that everyone was afraid of, and no one didn't know how to approach it, from which side. So this Russian fear and desire to do it the best. And then it got clear that you can organize the whole team made of surgeons, assistants, medical nurse. And for the first time, a medical nurse is a very full right team member of this team, and anesthesiologist. And all this training process and this ongoing training related to this robotics infrastructure. And all this, of course, came to us. Now it seems like quite a long time ago, but it was just a couple of years, and now we are already in this assembly talking about it. We have a wonderful roundtable aimed at this incoming of machines. So if we talk about these machines that are coming, so first thing I thought about is this, if we talk about machine invasion, is this part from this well-known movie. Maybe that's what we are thinking about when we talk about machine invasion. Maybe that's what we are thinking about. But if we remember the movie, everything started very good and finished also quite well. We'll talk about it in the end. But of course, that is not what we are talking about today. We're all talking about classical surgery, and many specialists starting this robotics surgery, they asked, why do we need all these innovations? Why do we need all these novelties? That kind of ruins the tradition that many people think, the traditions of classical surgery. Why should we introduce something new? What do we lack? But if we have a look at some data, then we'll see, for instance, classical surgery have quite a high level of complications. I'd like to say thank you to Professor Matri for slides that we'll show later in this presentation. Alex, if you want to comment on anything, please, you can interrupt me. No problem at all.
Thank you very much, Konstantinos. Good morning to everybody. I believe that this is indeed very important. Why do we need innovation? I believe there is only one reason. That's because in surgery we always want to go for better tools, to be able to give better results, and if possible, being less invasive and having less collateral damage. So I believe this is very important. Another thing, and you mentioned it, is training and education. Training and education is extremely important. A fool with a tool is still a fool. And so you can give me the best violin. If I am not able to play a violin, I swear to you that you all be gone in 30 seconds. But give me a Stradivarius and you make me train a lot. Only then we can have the better notes coming out. So the same is true with innovation. So it is our task to make sure that innovative instruments can be sent to the market in a very safe way. So just to give a laser, it's not because we have the diploma of a surgeon that we can work with all the different tools, bisturi, laser, robot, name it, whatever. It is impossible. It's like in aviation. We are today 2020. Can you imagine 2020, and still today we are training the juniors in a real OR on a real patient. Look at aviation. They have to spend hundreds of hours on a simulator before they can even enter the cockpit. So coming back to what Dr. Kay has been saying, before we look ahead and look what we have in the pipeline, let's look backwards. When we look at these complication rates, you have shown these complication rates of colorectal surgery. 1 out of 3 has a minor or a major complication. When we look at hernia surgery, 1 out of 6 has a minor or a major complication. We don't show urological complications because we don't have any. I'm joking. But it's like buying a Tesla, and 1 time out of 6, it's not coming out of your garage. That's not good enough. So I believe that this has also it's not only very bad for the patients, but it has also a lot of healthcare issues. We know, I don't know if you show the slide. Okay, I will leave this to you. But I will leave you. So these are my little remarks on that.
So healthcare cost to treat complications in the US, according to the statistics, and we received this data from Professor Motri, we can see that the cost 41 billion US dollars per year. So overall cost of surgical treatment per year 170 billion. So we can understand how expensive it is to treat complications, and not to waste this money. We can only when we reduce the number of complications. What we can achieve through what Professor Motri told us, when we bring innovations into surgery and train and teach and standardize. As Steve Jobs says, innovation is the only way to win. So if we talk today about innovations in medicine, in robot-assisted surgery, so this picture that you can see right now, I think you all know it quite well. Here we can see a surgery system Da Vinci. So we'll not talk a lot about it because Intuitive Surgical Company, who produces this Da Vinci system, is a monopolist. And so here we can see the system that works now. So SI system to console system. If we talk about the evolution of this robotic Da Vinci system, we can have a look and see all the way that this system passed. At the top left corner, you can see one of the first surgical systems, System Zeus, so-called. Computer Motion Company offered such a system. And so the system was used quite by a limited amount. Then Intuitive Surgical bought the rights for the further development of robotics. And in 1999, we saw the first the surgical Da Vinci robotic system. It was called standard system. This system had 3 arms, and later one more arm was added. In 2006, Da Vinci S system appeared that had additional arm and high HD visualization. Then 2009, 2014. In 2014, we had this development and presentation of Da Vinci Xi. Now it's the latest, the most recent model, which is the most popular and the most efficient and is used in many, many countries of the world. Unfortunately, in Russia, Da Vinci Xi is not registered, but we hope that the registration will be done quite soon. And of course we want to work on this system as well. So later, if we have a look what can be further, we can see the next development by intuitive surgery company, Da Vinci SP, single port. So surgery will be done through one port, through one incision, using such tools. So the manufacturer calls these tools snake tools. And if we have a look, let's have a look again at these tools, we can appreciate how small a space you need to put the trocar into the human body, and how small, what kind of small amount of space you need for work now. But it's all for the future, maybe not so far future, but for now we see some publications related to use of this system. So in PubMed we can see 137 works, and the last one was published in 2019 that assessed and discussed the results of different works related to use of this SP system. And as when we develop any system, as at the beginning of the robot-assisted surgery, so all these publications are mostly descriptive, so just initial experience. We don't have comparative works. Mostly there is no more than 50 cases that are being studied, but with time we hope that this development will be introduced more and more and will become routine, will be used in routine practice globally. What's about the global statistics of this robot-assisted surgery systems Da Vinci? So today they are monopolist. In the world there are over 5,000 systems installed, about 6 million operations per year. And in Russia the situation you can see at the slide.
10 cities, 33 systems, and today we have about 14,000 surgeries that have been performed. The most popular surgeries in the world, as well as in Russia, is robot-assisted prostatectomy, and we can see that the growth of these surgeries is growing. I mean robot-assisted radical prostatectomy, and we have performed maximum number of surgeries at our clinic. It's the maximum number for Russia. It's over 2,000 surgeries, and intuitive surgeries company says that every 36 seconds the surgeon starts surgery using Da Vinci system. This is the data from intuitive surgeries company, and taking into account such a big number of systems and the growing number of them, I guess it will be like that, and it will develop in the future. Yeah, it's true. The data that we have at the moment is true, so I'd love to ask Alex and other colleagues. I would like to ask you about one-port robot-assisted surgery, single-port surgery. What do you think about the single-port surgery? What's your attitude to it? And can we say that the clinic that performs robot-assisted surgeries should try to introduce single-port surgery in their routine practice? Как мы видели на видео,
Okay, this is magnificent technology. This is beautiful. The only thing that we have to question is how costly it will be in comparison to the classical robotic tools that we don't know yet. Number two, you must know that only 0.5% of surgeries today are done robotically. So there is a very broad, wide field there that is ready to be filled in. So I'm convinced that this single-port robot will really be the new step in robotic surgery. You will be able to do, like, let's say, single-port, classical but it will be very useful for ENT surgeons. Probably you will be able to do transanal or transvaginally some surgeries. I could imagine that for the abdominal surgeons, you will have a very easy access through the 4 quadrants of the abdomen, and this is with classical surgery with 4 different arms not possible for the moment. So I strongly believe in it. Will it take over the things we are doing now with the 4-arm robot, like for example prostatectomy, partial nephrectomy? You will certainly be able to do the surgeries with single port. But I doubt that this will be advantageous to use that single port, because you need anyway a second port to bring in your needles, etc. So I doubt that this will be an advantage, but it will have new fields that will be able to be filled in with robotic surgery through that single port.
I would like to repeat my question. Today, Intuitive company. So I have to understand this as a chief specialist. Should we ask for permission? Should we register one-port robot? Because it's a separate machine. Because we would like to know your opinion. Can we introduce this in everyday practice in such a big city as Moscow?
Good question. Let's be very practical. My department, we had last year 2 SI systems, 1 XI dual console. We changed it 6 months ago to 2 XIs, 1 X system. Why this 1 X system? Because we want to be ready to buy the first single port available in Europe. Because I strongly believe that the SP will offer us possibilities to enter other fields that we cannot cover today with a classical robot. And I look mainly towards intestinal surgery, abdominal surgery. So I strongly believe that it will have its place, that it will be added value, but if you have one system and you have to choose between the 4-arm or the single port, I will certainly say choose for the 4-arm robot. But when you have the several robots available and you want to cover the different specialties, ENT, abdominal surgery, gynecology, name it, there I think there is certainly place for an SP robot.
So speaking about single-port surgery, we have been talking about the trend that we see in robot-assisted surgeries. Many companies that develop the technologies, and we'll tell you more about such companies. So these developers decided just to stick to single-port systems. They think that this system would enable us to perform surgeries as effectively as possible. Of course, only time will tell us whether it's true or not. But I think that if we have only single-port machines in our clinics, I don't think it's the right thing. Just like Professor Motri said, it's good to have additional arms when we think about different operative interventions. I think, for example, if we take urology, including radical prostatectomy, I mean XI system. So it's easier and safer to use as comparable to single port. But of course, again, the time will tell. So it's not only urology. Intuitive Surgical company develops other kinds of robotic systems for other surgeries. For example, a very interesting robotic system was presented, and we talked about it with Professor Motri the day before yesterday. So this is the system which is a flexible robotized catheter for bronchoscopy. in order to enable minimally invasive access to lungs, to perform different manipulations in hard-to-access places. So this is the video from Intuitive company. So this bronchoscope it's controlled by a surgeon and by automated vision. Then you can do biopsy, analyze the state, and then do some diagnostic or medical manipulations if there are certain malformations or malignancies in the lungs. We discussed with Professor Motri that this flexible approach can be used for pulmonology. There's robot Avicenna that is performing otoscopy. And this approach also has a future, and it's going to be used wider and wider.
So I believe this is again a very good example how robotic surgery, robotica, domotica, when we look at our cars, when we look at the kitchen of my wife, for example, you see that everything is becoming robotized and domotized. This is also true in medicine. It is unbelievable, this machine, if you ask me. The best pneumologist has 2 chances out of 3 to be able to take a successful biopsy of a coin lesion. With the robot, 95% chance to have a successful biopsy. Imagine, don't forget, this is a very aggressive cancer. And if you don't know what it is, you have to say to the patient, well, let's wait 3 to 6 months and take a new CT scan. If it has grown, it has, then it's cancer, we have to take it out. This means that we give 3 to 6 months extra to that tumor to metastasize, to grow with worse outcome for the patient. So, and don't forget, Intuitive Surgical is a very intelligent company. Last year they have changed their name from Intuitive Surgical to Intuitive. That seems very, very basic, but it's a huge step. That means that they are now really entering the market of diagnostics, etc. And they have made this company is in a joint venture with Fusion in China, and their first place where they built this is in China, because there are over 230 million smokers, and they believe that will be their biggest market.
Getting back to improvements and innovations in robot-assisted surgeries, I guess all innovations could be split into several groups. When we speak about robotic surgeries, we speak about the advantages of them, and the first one is visualization. An excellent opportunity to visualize all the anatomic structures that we have seen when we had open surgeries, but now we will be able to see them even better with high quality, and we'll be able to work with them at a higher level. We speak about robotic anatomy that help us to perform functional surgeries and protect important functions for our patients. And innovations include visualization, combination of images, imposing one image onto another in real time, using tile pro system, fluorescence, using different 3D technologies, beginning with 3D images, 3D reconstructions, 3D printing, navigation systems that are used very often for neurosurgeries, and the system for tissue identification. We are using electronic microscopy of high resolution and automation. I guess we are all moving towards automation, no matter how sorry we hear about it, how sorry we are when we hear this. And some specialists will be removed from the process at certain points.
So this is an example where we use innovation to make surgery safer. So this is using the 3D reconstructed imaging from the CT scan, and I have now a iPad mounted on my console where I have direct access to these 3D software, and I can bring this into the console and so make a safer surgery. You can also print this into a 3D printed models in the very complex cases. Can be useful to have really the kidney in your hands before you go for the surgery.
Я считаю, что технология, которая представлена здесь на данном слайде, это
Yes, it's true. The technologies that we see here are the technologies of the future. And we can have these technologies already today. It sounds like a dream to see such a great image, especially when we have to see all the slightest details in kidney. It's very difficult to identify and recognize the anatomical structures, and we have to do it. So we're using Tile Pro and augmented reality technologies. You can imagine where this tumor is located, so we can remove it carefully. We can choose the method to remove it, and we can identify the appropriate method of clipping and appropriate surgical intervention. If we speak about fluorescence, Firefly system is being used in robotic surgeries, and it can help us to visualize the structures that have to be identified. Sometimes they are not well seen with normal light, so that's why fluorescence can help us to identify it, and it can help us to achieve high precision. If I think about urology, it works very well for kidney surgeries. If we create a flap, if we create certain anatomic structures that require protection of blood supply, this is also very important. And that's when we can use this technology. I know that Professor Motri has a lot of experience using fluorescence in Europe. Could you comment on this?
I think Dr. Kay, I think you're very right. This is again some innovation that helps us to bring, it's a very good example how innovation can make surgery safer. Just one example. I have been using fluorescence since 8 years when we do neobladders. You know, to operate on bowel and to sew it after having taken out a piece and you suture it again, the biggest danger of colonic surgery is bowel leakage. When you have bowel leakage, fluid going into the abdominal cavity, the mortality rate is quite high. This is the highest, the biggest problem you can get. Don't think it is because of the surgeon is badly suturing it. The major cause of bowel leakage is that the ends of the bowel are hypovascular, and so they tend not to heal well, and that's how you get bowel leakage. I am using this technology since I think 7 or 8 years. We were actually the first to use this for this indication, where we looked at the vascularity of the bowel ends, and let's touch wood, since we use this fluorescence technology for this reason, we have never ever seen one single bowel leakage again. So just to tell you that this is very important. Another indication is visualization. Dr. Henk van der Poel from Amsterdam is doing a lot of work on imaging of the lymph nodes. For me, I don't know what you think about it, lymphadenectomy is for me the most frustrating operation. Why? We don't have good imaging. We don't take out lymph nodes. We do fatectomy. We take out fat and we hope that there are lymph nodes in it, and if possible, those who are invaded with the cancer cells. So because we don't have good imaging, you have the very nice example there where you have shown a video clip where we can visualize suspected lymph nodes. So this again could be a very good thing, that we could have less collateral damage, because taking out all this fatectomy, think about breast cancer, and doing lymphadenectomy of the arm, you risk to have lymphedema of the extremities. When you could only take out the lymph node, you will have much less collateral damage for your patients.
Спасибо большое, Алекс.
Thank you very much, Alex. It's true, fluorescence help us to achieve better results. Another very good example, and you can see it in real time, it's ultrasound intercorporal study. So we can see what it looks like on the organ itself, and it can help us to recognize the tissue. Maybe this tissue recognition can be improved better in the future, but we can identify vascular nerve components and improve functional results of surgeries. Something that seemed to be impossible 5 or 6 years ago. We thought that it was only a dream, but now we can see it not only on the screens here, but in our daily practice as well.
So education, what we talked about today, let's talk a couple of words. Education also changed. If we talk about education of robotic surgery, so it will not be enough time that we have for this roundtable. We can talk about it for very, very long time. And education includes many, many different parts. So it's very modular, it's very specific. For instance, through some virtual simulators that pass the whole way from the very simple simulators that you could perform this or that task like a computer game. Now we can see augmented reality virtual simulators with some pre-recorded operational performances when a student performs a surgery, and an image is live, and there is a complete feeling that you are operating in live. And you can also look some material, you can change some options, you can make mistakes and correct them on your own. And it's a very important thing. And Professor Matri, who is here with us today, we're very lucky today that Alex is here with us today, because Alex is the leading specialist and developer of programs of education of this robotic surgery in Europe. Alex, can we ask your opinion about education? A couple of words, probably a couple of points, if you can.
Yes, so thank you very much. I already stressed a little bit in the beginning today about the way that that training is becoming super important, because technology is becoming more complex, and if you can't work with it, you will not have good outcomes. And I'm so thankful to the two speakers here next to me, Professor Pushkar and Dr. Kay. I think what they are doing is fantastic. So we are collaborating a lot in what we call quality assured training. With this novel way of training, we should be able to lower complication rates with 50%, 50%. I don't know if you remember the data that has been shown by Dr. Kay. The readmission rate in the USA on a yearly basis, $41 billion. We know that half of them are due to complications. $20 billion. Imagine with a novel way of training in a safe area, in a lab, in simulation, out of the OR, we will be able to lower the complication rates with 50%. That means when you take into account the cost of complications, only the readmission costs, that means a cost saving in the USA of $10 billion on yearly basis. Can you imagine how many robots you can buy with that? It's, I believe, extremely important that we work together. And we have made a society together, and together with Professor Pushkar, we really want to push the wagon and to try to change the way we train the juniors in a better and a safer way, and this on world scale.
I'd like to say a very important thing to our Moscow urologists. It's not only in Moscow, it's in many countries and cities, that for now we haven't learned to calculate complications, to measure complications in a way that how it's supposed to be done, to measure complications, to calculate the price, the cost of the complications, the expenses that we can reduce, that we can save while using new technologies in our education, in our training. So for all you to know, all the chief doctors, so it's the next stage. I don't know if Makasyan is here or not. He's making a study in Moscow, and everyone participates in them. And from such studies, without such studies, it would be very hard for us to defend tariffs and defend the emergency care. And so that's what we started talking about it. So I'm telling you that because the analysis of our activity, of our work, of urology work, it's not only the analysis for the amount of treated patients. We talked about it. It's not only the amount of treated patients, but it's the analysis of what the functional factors. So where these patients went after the surgery. So it's a very complicated conversation, and we should start it. It's very important. Of course, I understand that's what we're talking about when we calculate this money, because when we see that sometimes it costs 40 billions, and we think it's not about us. But you understand that this assembly, that it is about us. Thank you. So talking about education. Education is possible today at a totally different level, thanks to we're gathering so much information as we have big data and all this robotics surgery. So it's a very new thing, and it required a lot of data gathering and analysis of this data. And for instance, what you can see at the screen right now, it's just a fragment, just an example of what kind of data can be received when we analyze the work of a robotics system. Intuitive company today made huge infrastructure, and this huge infrastructure allows this company to continue being the monopolist in the world. Each system, as you know, it's connected to the internet and all the data. So everything that's happening when you use the system, they're translated as special logs, and there are special interface. It's called the Vinci research interface. It's not available for the large public. So if tomorrow we want to assess the work of our center and understand how our specialists work, not through some objective indicators or subjective indicators, but through cinematic factors, the movements of their hands, amplitude that they use for this or that manipulation. Unfortunately, we will not be able to do that using this interface. But still, there is such a work, and we can see that such an approach to assessment, how to improve the qualification of the specialist, how to improve the basic level of the skills to make this or that manipulation is present, is here. It's quite interesting if you look at the slide, this kinematic model. You can see it on the right. So the left column is this kinematic characteristics of expert level, and on the right you may see of a novice surgeon. So red and green, so left and right manipulators, and black, it's movements of the camera. So even such small example allows us to assess the difference between an expert and a novice. So this infrastructure that is built in by this intuitive company, the approach to this assessment of database allows us to train better as well. Today, though the intuitive is the monopolist and Da Vinci is the only system that is working in robotic surgery at the level that it's necessary, of course, not only Da Vinci exists, and that is very good. And we want that there'll be more and more, not only Da Vinci, because it's the first and the right way to what we dream about. What do we dream about? We dream that this robotic surgery would be available to everyone. We dream that systems cost much less, that disposables cost much less. So we dream about a lot of many things, that the whole system weighs not so much as it is now, and the size would be much smaller, and of course many other things that can lead to decrease of costs, of expenses, that can make it more affordable and available, and of course higher efficiency. Of course, not only us, but over 50 companies are developing all over the world different robotic systems. And for instance, today we have already some amount of developed systems, and we have some systems that are commercially available today. And now we're going to talk about this. So, change the slide, please. So if we talk about robotic systems, so we published this methodological recommendations, robot-assisted surgical systems. We thought it's very interesting and helpful. And talking overall about the approaches of creation, so you can divide robotic systems into several components. So today, Da Vinci system, which is the most popular, this system works through master-slave principle. So the master is at the console, so slave is this HUD with patients, and it repeats what the doctor is doing. So they have different console types and the components of all these arms, how you control the camera, some presence of special capabilities, presence of the single port access. So we sold this system today that you can use for this, and also decision-making system. Here you may see the system which is available now commercially. It's called Senhance. Before it was Tricenterix Alpha-X. So in 2017 it was first presented in Russia, and we can assess here the size of the system. We can see it quite clearly. The system is bigger. So I'll show it to you again. So each robotic arm is placed on a different console. That's one big difference of the system. Another big difference is that the surgeon is sitting and looking at the screen through 3D glasses. And if you look at the manipulators handles that surgeon's operating, you can assess how it's similar to laparoscopic tools. That's all the trick. So the creators of this system thought that the big amount of laparoscopic surgeons did not switch to this robotic-assisted surgery. And for instance, that it's very inconvenient for them, not very useful for them to manipulate these Da Vinci handlers. And one of the ideas here was to attract a big pool of these laparoscopic surgeons who are outside this robotic surgery to bring them into this robotic surgery. Now we all know this attempt was not successful. Alex?
I believe that indeed this exists already many years. And as you say very nicely, let's say the difference between classical lab and this type of robot is not very big. But there are quite a bit of let's say, disadvantages of this robot. It is less precise. It has only one instrument who has a movable tip, and it has only one articulation. The cost of it is like the Rolls-Royce of Intuitive. It's cost 2.3 million euros for something that is basically, for me, used to work with the Intuitive one step backwards instead of one step forward. One other drawback, they don't have money. They sell only very few systems, so that means that they do not have money to invest in innovation on their robot. So they are already many years just the same, and they didn't improve.
And in fact, a very important moment in robotic systems and the difference from the laparoscopic system is the possibility to articulate through different tools. And in this system, just one tool, this needle handler, have these possibilities. Other tools don't have it. Of course, many things are not successful in this system, but still the system is available commercially, as well as, but only in Korea, this Revo Eye system. If you have a look at this picture, I found it in a magazine. So this picture, if you look from afar, it's like the same copy of Da Vinci, and many companies followed this way. They tried to copy Da Vinci system. Is it a good way or not? It's hard to tell. But in this specific case, it's the first generation. There is a second generation of this Revo Eye system. The system is approved only by FDA in Korea and can be used only in Korea. And I paid attention to one publication that said that if in Korea hospitals, if they have both Da Vinci and Revo Eye system, so they use Da Vinci system. So our colleagues who were sent by the healthcare department to a Korean clinic also confirmed, so seeing two systems together, Da Vinci system only worked. And I think that's the main characteristic of this system. So switching now to others, being developed systems. So we can talk, I think, about T-Sport system. So Titan Medical Company is developing the surgical equipment, and using the example of this equipment, we can understand that this company is following only using single port, believing only in single port surgery. So here is before clinical trials, single port. So here we see the patient. And so what Alex told us about, there is one more port for assistant, which makes this single port approach is not exactly single. So the incision is very small, just 3 centimeters. It's an advantage of this single port surgery. And there is a short video, so before clinical work of this system on an animal, partial resection of a kidney, now ligation on the kidney vessels. You see tools, but I think the work of the tools is not that precise as we would like it to be. Maybe because of this, of the change and the change of kinematics of tools. But though procedures are performed and it's successful, and this system now received the second generation. But from what I know, commercially it's not yet available, and it hasn't passed all the regulatory mechanisms. Integrated simulator. The system also has an integrated simulator, so they think about education as well. That's good, because when you develop a new system of robotic-assisted surgery, you need also think about the whole infrastructure, about all the moments of education, including virtual integrated simulator, including some other mechanisms. So that's what I told you before. So these kind of simulators, you can call them like simulators of the first generation of simulators, when we could perform such quite small computerized actions, a bit like in a computer game. The idea here is just to improve the skills of work with tools, with manipulators of this system, unlike all these integrated simulators and devices that allow us to make live surgeries.
About Titan Medical?
Yes, unfortunately, I wanted to ask you the same question. I'm very, very eager to know more about them, and I can tell you that by accident, when I was here in Moscow, I got the approval that Medicaroid will come and visit Orsi Academy next month. So I will only know more. I know that they are on the market. I know they are building on something. I know they have heavy support from a big company called Kawasaki. But I've never seen the robot, so I have no idea. I don't know if it's single port, if it's multi-port, if it's diagnostic. So happy to see your video.
That's the only video that there is for now. So the company is developing and announcing the development of such a system. And so here we present it because it was announced.
So by today, 2020 and 2022, we hoped to get some information, but we haven't really found out much. And the system which is probably having the most of potential, this is the system that you are seeing now on the screen. It's a CMR system. It used to be called Versius. It's a very short video that demonstrates the system. As you can see, the arms are placed on different isolated parts, so you can increase the number of arms or decrease them. You can see the joystick. So the surgeon is sitting in front of the open console. He is wearing 3D glasses. Very different layout of the instrument, different approach to interface. I guess the surgeon will be able to have more opportunities online, because they'll be able to use some settings and make adjustments as they need. And maybe CMR is the system that will be used in the near future on the market.
So I strongly believe in CMR. I think they are clever. They don't want to compete with intuitive. Let's be honest, they are very alike as a system, but it's less good. You have more tremor in the instruments. It is just a little bit less precise. But number one, they are aiming for benign pathology, hernia surgery, benign gynecology, etc. Number two, they will be much cheaper. You will not have to buy the machine, but they will probably ask about $2,000 per case you perform to use the system, plus the disposable instruments. Number 3, they are really working to get on the market this year. And this could be the first real competitor we have available. They are, as we speak, doing on-man studies in India. So we hope that they will be on the market very soon. They will come to Orsi Academy as well to give their trainings. So if you come with your team, hopefully we can also show you the CMR robot.
Спасибо. Мы все надеемся на то, что наконец мы уже
Yes, we all hope that we'll be able to get a system that would be competitive. Or maybe not as a competitive, but just as an alternative to the Vinci robotic system. Autonomous robot surgery is one of my final slides. And this is the slide from Professor Motri, and maybe this is what we should aspire to. Certain actions without the participation of the specialist. And you can see in the left, you can see a video in the left corner when the system is doing this incision by the system itself without any specialist control, without any person's control. Do we need it? Is there a real need for that? Do we need to use such systems in the future? It's a big question. Maybe at some stages we will need it, but I guess it's up to a surgeon to decide. But anyway, we can see such things happening. So what do you think about it?
I strongly believe that, number 1, we are too optimistic to use our tool, the robot. So even the intuitive robot is not a robot. It is a master-slave telemanipulator doing one thing under our control. That's number 1. So we don't have a robot. This is a robot. It looks very basic what he's doing there and cutting that circle out, but this is a huge step. This proves that this robot, this telemanipulator that we are using today, they can change it into a real robot doing automated surgery. Whether that will be on the market soon for abdominal surgery, prostate surgery, kidney surgery, I don't think so. Not yet. But remember that bronchoscope you've shown, you have seen they use the CT scan, they make 3D reconstructed imaging out of it, and it is like a GPS that shows very nicely to that robotic serpent where to go. Plus, it will have tissue recognizers at the end, so that you will not be able to perforate tissues anymore. And we must know that a real robot can do much better and much more precise repetitive movements than any one of us can do. So I strongly believe that the first application of real automated robots will be rather in endovascular, endocardiac, and into these diagnostic robots. And believe me, or don't believe me, but these real robots will come there and much quicker than we think.
Спасибо, Алекс. Ну и
Thank you, Alex. And my last slide. Machine invasion, expanding indication. It's Professor Motri's video. It's just to demonstrate that Da Vinci system can perform such surgeries. I think that we have lived through many interesting things, but still we are in an emergent state. And I guess we can expect a lot of robotic systems to be developed, a lot of innovations and things that we would like to see as part of robotic systems and equipment. So we keep dreaming. We keep dreaming that the world becomes a better place, that robotic systems become more comfortable to use, more affordable, and we keep dreaming that robotic systems should come to our life, and so they will be working with us and help us. And we don't want to have such end as you saw here in this video. Thank you, Konstantin. Well, you know, machine invasion is reality. And if you can turn on my presentation and show it here, I can say that machine invasion is a reality. And first of all, this is something that we carry in our pockets. So this is a device or a machine that is used in our daily life, or we use it every minute. But still, there's also real life going on. So Professor Kolontaryov, that organizes training for our specialists in Belgium. What we show you here was happened at our bases, and it's all about improvements. So we show what we're already doing, and it's not only about talking, you know, yeah, we'll do this this way, but we know that this could be improved and you can make it better. And there are details that the health department and the mayor's office asked us to demonstrate. You know, machine invasion has happened, full stop. Now, if we go into biomed, we can see 10,000 of papers about robotic surgeries. Most of them were published by Professor Motri. Some of our works were published by us. And the urologists that work with prostate cancer understand that we have had a lot of experience of open surgeries, and we could never see such imaging when we performed open surgeries.
So it was not possible because we had a bone on our way, this pelvic bone symphysis, and whatever patient you have, we remember, and here we have a seasoned specialist that such a patient, quite a small, thin patient, and everything was good. Everyone admired that, and now when we had yesterday a full patient, so we understood that it will be a big surgery, a lot of blood loss in any hands, and so today we can say that we have average blood loss when we have robot-assisted surgery about 75 cl. So from 5 to up to 200 cl, and so for a patient who has this prostate gland is quite big. So here you may see fully keep all these nerve bundles. And we understand that today it's a normal picture for all of us. But just 15 years ago, we didn't have such an image for such surgery. So here its speed is twice as fast as to show you the of radical prostatectomy in our clinic. So it's made the same way for everyone. So we also do make RC when we in a RC when we bring our doctors. So we make it on dead material. So the full surgery. So we keep the neck of the bladder, and then we can, with the third arm, we can take the prostate gland and move it closer to the symphysis to go to the space between the prostate and the bladder. What's interesting is when we perform open surgery, we are not talking about laparoscopic prostatectomy, because this surgery is left because a specialist who starts performing it should make 200 radical prostatectomies to learn this technique if we talk about laparoscopic surgeries. And we can't allow in Moscow for a specialist to learn on 200 people. It's a crime. So now we're talking about open surgery that exists, it never left, and robot-assisted surgery that you can see here. We understand that when we have an open surgery, such structures, we can't see them. Well, we see them, but we see them differently. Why? Because to go from this part to open these pedicles of prostate, so to come to this nerve vascular bundles, it's not possible in the open surgery. What does it tell us? It means that I have a specific task to introduce this technology for all urologist departments of the city. And I'm saying this when the methodological department is recording me online. I don't have nothing to hide. That's my mission as chief urologist. Yes, it's not easy because we didn't calculate the cost of complications, because we didn't calculate the cost of complications because we don't think about it, because we haven't shown that if we make the surgeries openly, then the function of these patients will suffer significantly. So we understand that we can't do that 24 hours per day. We're already doing a lot when we have this invasion of machines. Look how we can separate and clip this vesicle, this part, to approach the prostatic pedicle to keep the nerve vascular bundle. So we talk about colon. The trauma of colon, it's quite a rare situation. It's a very severe complication. So people who work, they face this kind of trauma, try to correct this during the surgery. It's not always possible. It may be quite a severe complication. We should also calculate it and talk about it. Nevertheless, we understand that here, if we speak about some not complicated, like T1, T2 patients, so colon is quite easily visualized here. We show different clips that we can use. So white clip, hemlock, but it may be different. We use this kind of clips for me. Yes, it's metallic clips. They're different, of different size. And Alex Matri doesn't understand that, but in Moscow we are talking about clips, and I know that every department has clips. In Moscow we talk about hemlocks, and I know all urologists understand what I'm talking about. It's very important. Why? Because you should understand it's very big, very long way that Moscow passed to that we could talk like that in the same language as about prostate. So here we separate it from the colon and we approach the pedicles, that then each patient has they go to these neurovascular bundles, and when we have robot-assisted surgeries, we always separate antegradally, because if we speak about retrogradally, when we have robot-assisted surgery, it's almost impossible. Nevertheless, we're trying to come closer to the prostate, and Alex told us about it yesterday. We want to be closer to the prostate. So that, like that, very carefully, to enter into the space between neurovascular bundle and prostate, to come to this layer and make this intrafacial dissection that is described. It is described many years ago. Like that, we continue our separation, and you can see that this separation is continued from each side, and you can see that we come to the layer where we can just remove both and laterally prostate through using the third arm, and come to the layer with the low risk of prostate cancer, allows us to keep completely this all neurovascular bundle without any action with it. And it's very, very important because all the nerves, so it's they're very small, and if you keep the nerves, then you keep the function. And for such a patient, erectile function and urine continence is, of course, this question that will be solved, and that's important because yesterday almost all the specialists in the room Simashko, voted for screening. I'm not sure if Professor Kalantarev was there or he was in the clinic, so you could see. So Dr. Kupriyanov and our professors and specialists from methodological department saw that all voted for screening. Why? Not because screening is something unreasonable. It's not that we make this PCR analysis to 45, 50 years old man. No, we're talking about screenings like early diagnostics. And in the country where we never had screening, in Russia, in Moscow, now talking about that screening is not needed, it's a crime. Because screening and early diagnostics, it's the same thing here. So it's important. We never had screening, but early diagnostics and regular checkups that we had, of course we should maintain it, because it's important. That's why when yesterday everyone voted for that, I thought, look how unanimous it is, how good. So we shouldn't even discuss it, so no arguments, because all the studies, and urologists know about them, PLCO, so they are not sustainable. Why? Because today we are fighting, and today it's -2, -3% T3, T4, and when we started this talking about this problems about diagnostics, and Alex will be interested to know that in Moscow 60% of T3, T4 prostate cancer. Now it's 35%, and that's a very important moment. So it's success of early diagnostics. So we continue separation of this nerve bundle on the left. We also continue this. Fascia is very well seen. Here, no hurry. Surgery goes from the left in the same way up to apical dissection. And apical dissection, that will be shown in a couple of seconds. Apical dissection, like that, is continued. And the prostate is now almost all naked, up to the neck of bladder. Here we can easily use coagulation on the parameters that we usually use for it. And we're approaching the dorsal venous complex that will be sutured. And the surgery will be finished when we sew through this dorsal venous complex and connect the neck of the bladder with the urethra. So this surgery will be shown on the 18th February, together with Professor Kalantarev at Lopatkin's readings. So all urologists will be invited. So we will be glad to see you there, so we can see the urethra. that will be separated and opened, and it will be open close to the prostate, because this patient of the low risk. So that's how we make this radical prostatectomy. Alex would like to comment something.
Well, I just want to congratulate you with this fantastic surgery, and I would like just to say to the people here that I am super grateful to you because as president of the European Robotic Association in urology, I think that your work is magnificent, and just to tell you all that Dr. Pushkar is very involved. And I have to congratulate you because you talk about screening in Russia, bringing the robot into Moscow. I can tell you that you bring surgery from Russia up to world level, so that is great.
Thank you very much. I'm very glad to hear these words. I know that our Moscow surgeon and Russian surgeons are very good specialists. I'm convinced. And that's another patient already. So that's how we make suture. So this lateral reconstruction, here there are, so here it's neck, and you can see neofix of the membrane, of the cellular membrane, that sometimes we use for patients, for young patients, like that. We connect the urethra and the neck of the bladder, and at the same time our nurses help us with catheter that's moving on different sides. You see, it's very important. Of course, if you're just alone, you can't do that. And as for the results, that's the result. So the result should be like that. So the function at any weather, the function at any place. So I'm very welcome again, Professor Matrikhi. I'm very happy that you came here in Moscow with wonderful presentations, with your opinions, with your center that provides so much support to our Moscow specialists. It's a big honor for us. It's very nice, and from our side we want to promote this and develop this area, and we'll do everything we can. Of course, we'd like to have your help and support. And I say thank you to everyone who fights against the machine invasion. So we are doing this every day. So thank you, Professor Kalantarev, for wonderful report and discussion that we had today. Thank you. If there are questions, dear colleagues, we have a couple of minutes for questions. Please don't be shy. Thank you and good day.